Now, basically, we've got two lasers in our clinic. We've got the M6 and we have the M5 with the Charlie head. The M6 is probably my favorite, to be honest. It covers a bigger range and things. So, as you probably know, it puts out sort of two different wavelengths. It's got a maximum power wattage, so we're not doing any thermal damage. And basically, you do get some training, which Kirsten does a lot of, which is excellent. So what we have here is in clinic, basically using it on plantar fasciitis. This is one of my team. I wouldn't use it this way. If it's the handpiece, I would always move it towards the heart with the handpiece, and just kind of work on it. Sort of move it towards the heel, move it towards that area, and focus a little bit on the heel. The Charlie head's a lot easier. You just kind of set it to the power level that you want, leave it to run, and yeah, after the time limit stops, it's very good. The M6 works in a similar way, but it will actually move up and down the area, which will cover a bit more. So what I'm going to do is cover a little bit of how we treat plantar fasciitis in clinic. We've made up a set of protocols for it. So generally what we would expect with our protocols is to get a reduction in pain within 24 hours, lasting up to a week from the first appointment after laser. We put together a rehabilitation package, and usually we've got really good results within sort of 8 weeks. We kind of recommend between 4 and 8 sessions of laser to people alongside the rehabilitation plan. Usually most people will go for about 6. Occasionally we'll throw in an orthotic, but usually the rehabilitation plan involves strengthening whatever weakness is causing the issue, whether it be something such as tib post, whether it be a little bit of restriction around the ankle joint, tight calves, something that's causing it. We'll have a look at what that is. We'll do a bit of joint mobilization and usually a bit of soft tissue work as well. Now, I prefer the patient prone, sort of on their face on the plinth. The reason for that is with the M6 and the Charlie head and the handpiece, I can treat 2 areas at once. So my kind of go-to is the tendonitis setting for both. So with the M6, I would use that on the actual body of the calf and up and down the Achilles tendon and just let that run. And I would use the handpiece for a tendonitis setting on the sole of the foot and around the kind of where the Haglund's bump formation is, around that area at the back, posterior aspect of the heel, going all the way forward to the metatarsal heads and kind of working that. There's a few other settings I tend to throw in there. Muscle contraction works really well, just kind of above the myotendinous junction in the Achilles tendon. So I would, again, tend to use that with the Charlie head M6. That just relaxes the Achilles and the calf muscles around that area, just to give you a little bit of flexion and just reduce some of the pain. Again, we use muscle contraction quite a bit with the handpiece. I'll show you the areas of that in a wee minute. Inflammation, if it's true plantar fasciitis, we'll use that around the medial tubercle of the calcaneum. Brachial neuralgia I tend to throw in quite a lot. It is my favourite setting of everything. That is in the neck and shoulders for any of you with MLS laser. I don't change too much off the settings. I'm usually quite happy to use the actual settings and go with that. So I'm going to talk you through. So we're going to look at the first image, which is the one here. So I tend to find quadratus plantae and quite often the abductor hallucis and the flexor hallucis brevis can both cause a little bit of pain around that medial arch, which can mimic plantar fasciitis. Even if somebody has true plantar fasciitis, I tend to find doing a bit of muscle contraction work around this area really releases it as well and just can help with the pain. What I tend to do is muscle contraction. It's in pretty much every laser within the calf or the thigh setting within there. What I do is I set it to 1 point, and I will set the time for about 4 minutes, and I will just move up and down the body of these muscles. Again, tending to go from the toe back towards the heel, back towards the heart kind of area, sort of moving with the blood flow. That tends to get a really good result, actually, just by sort of doing that and working these muscles, particularly since abductor hallucis can get quite weakened through plantar fasciitis. Just usually the arch is not that strong. Just having a little bit of muscle contraction just can take some of that inflammation out. Inflammation, as I've said, around the plantar, the medial tubercle. And if I'm still getting a little bit of pain, I'll focus on the medial calcaneal nerve and going down the medial plantar nerve and sort of set that to brachial neuralgia. Again, what I tend to do is that's a multi-setting and trigger points. I'll set that to 1 point, I'll set that to 4 minutes, and I'll just go up and down the area of the nerve. That tends to desensitize it quite a bit, and that's really quite useful at just relaxing everything and generally taking away that pain, which could be a bit more neuropathic and a little bit more due to involvement with the nerves. Combining that with the muscle contraction and using both of them more as a scan phase and a trigger point really seems to release things. We tend to do that if we've not had a result after about the third appointment with just more our soft tissue, with our joint mobs and some of our extras. But in general, we can get really good results within the 8 weeks by doing that, and using them as a 1 point scan setting actually makes it quite good, because you can target the area you want, you can target the muscle. I always angle it slightly, so don't go directly down with the probe. I always angle it and again move towards the heart, and that way it just seems to absorb better. Because the patient's prone as well, what I'll do is tend to either dorsiflex the ankle while they're sitting there. I've got my knee against their foot and I'll be moving that every now and then, or I will be flexing the toe as well, dorsiflexing the toe as well. So yeah, that seems to be our pretty good protocol that's getting decent results. So